And I'm really excited, as well as a bit daunted, to be honest with you all, to be chairing this important discussion panel this evening. As many of you will be concerned about the question of excess deaths and what we've called hidden factors and hidden threats. This is a discussion that we're hosting as part of the Together Social Care. One of our speakers who's going to be speaking first, Amanda Hunter, who's actually the chair of the Together Social Care in the Cabinet. And we launched the Cabinet, as you know, to put papers out, to have discussions in terms of the public realm, representing the interests of the public in the political landscape, where we think often, far too often, the public is sidelined and far too many technocrats or policies or impositions are made. And certainly there's nothing that's more important than life and death in many ways. And who gets to choose about that? So this is a vital discussion. We know that during COVID, there were many questions. And as we've said in the introduction, despite it being officially over, we know that official statistics for mortality for the first 3 quarters of 2023 were 5.5% higher than it was for the same period in 2019. Now, it raises all sorts of questions. We know that there were many reasons why excess deaths may have gone up. But leaving aside tonight questions around the vaccine and questions around cancer, heart disease, and all the other issues, we're going to be looking at the context of what's gone on with care homes, and particularly some of the protocols that families, bereaved families and others have been campaigning around, questioning the end-of-life protocols, particularly NG 163 and NG 191. Strange terms, the protocols, but we'll get into them a little bit more and what they mean this evening. Now, I want to get into this quickly because we've only got until 8 p.m. The format's going to be that I'm going to introduce the speakers. We've got a brilliant panel this evening. Also, one of the panelists, Andrew Bridgen, has to be in a debate at Parliament for votes on the Rwanda issue, another really big and important issue. So he will be leaving us just before 7 to vote. I'm going to get into this quickly, just to introduce the speakers. I'll just do it in this order, and then we'll go to the order of speakers. I talked about Amanda first. She's an English teacher and translator by profession, but she's been a social care campaigner by vocation. She's the chair, as I said, of the Social Care Cabinet team in Together, and has also been the co-founder of the campaigning group Unlock Care Homes, which campaign against care home and hospital visiting restrictions during lockdowns. Massively important issue. We know what happened to care homes, and we can talk a bit about that, obviously, as part of all this evening. And she's also a co-founder of the newly formed Families Against Involuntary Medical Euthanasia. Secondly, this evening speaking is Reverend Dr. Patrick Pullicino. Patrick's originally from Malta. He's a retired National Health Service consultant neurologist and emeritus professor of clinical neuroscience. In 2019, he was ordained and currently is assistant priest to the parish at St Bede's, Clapham Park, London. Now, Patrick raised concerns about the abuse of the Liverpool care pathway whilst working in the NHS and was influential in getting it officially banned in 2014. So we're very, very grateful and happy that he's joined us this evening. Andrew Bridgen, as many of you will know, is a Member of Parliament for North West Leicestershire. He served as a Member of Parliament since 2010, first as a Conservative and then for the Reclaim Party, from which he resigned in December 2023. He's now an independent MP, which he feels will enable him to better serve his constituents and standing up for the views of the public, in his words. Andrew's been at the forefront of exposing scandals such as the modern-day slavery cover-up in Leicester and the Post Office Horizon scandal, which is now obviously on everyone's lips and in minds. He's consistently raised concerns in Parliament around current trends and excess deaths, and yesterday morning led a parliamentary debate on the issue, and you should have a look at some of those streams and links. We've got them at Together Deck and elsewhere, so we're very grateful for Andrew joining us. And last, but of course by no way least, is Professor Kevin Yuill, Emeritus Professor of History at the University of Sunderland. Now, many of you will be familiar with Kevin's writing on end-of-life questions, assisted suicide and others. He's the founder and CEO of Humanists Against Assisted Suicide and Euthanasia, a project dedicated to questioning the legalization of assisted suicide and euthanasia. He's published several books, including Assisted Suicide, the Liberal Humanist Case Against Legalization, and numerous articles on a variety of subjects. Kevin takes a secular position against the legalization of assisted suicide, and you'll see him participating in debates, radio, and television interviews on the issue. So, just by way of saying, we're going to have the panelists all speak for around 5 minutes. I'm going to talk to them just about one or two things that may have come up. Then we're going to go out to some of the people here on the Zoom link. We've got a Zoom link and we've got a stream. We've got lots of people on the stream and on YouTube, and this will be part of an ongoing discussion and potentially campaigning work, which we'll discuss in this meeting. So I want to thank you all for joining us, and I would like to invite Amanda to kick off, please.
Hi, evening everyone. Before we begin to unpack what we believe to be some of the hidden factors contributing to the unprecedented excess deaths we continue to witness and the hidden threats these factors pose, I'd like to say how encouraged I am to see so many of you here tonight with us. Impacted families and grassroots campaign groups, some of whom are in our audience tonight, have been hounding MPs and government ministers for the past 4 years in an effort to raise their concerns and secure a thorough investigation into the unexpected or otherwise premature deaths of their loved ones. We have banged on media doors trying to bring our concerns to a wider public. But as the sub-postmasters found, few politicians and few mainstream media outlets have wanted to listen. And even when they have done so, the response has largely been to pay lip service to our concerns. I say largely, but there have been notable exceptions. And we are immensely grateful to the MP Carla Lockhart, who I will refer to later, and to our panel speaker, Andrew Bridgen, who has not only listened, but has been tireless in his efforts to secure a proper debate in Parliament in response to wider public concerns around excess deaths, as well as specific concerns we will be sharing with you tonight. We want an inquiry into this. Despite the pandemic, or if you prefer, the public health threat posed by COVID being officially over, excess deaths continue to rise. As Alan said earlier, according to official statistics, mortality for the first 3 quarters of 2023 was 5.5% higher than it was for the same period in 2019. New figures apparently come out tomorrow, and there's a real problem with how these statistics have been collated, because instead of they have been using 2020 and 2021 as a baseline for the excess deaths. This should not be happening. And Andrew Bridgen has spoken about this. The vast majority of those deaths are not attributable to COVID-19. And leaving aside possible vaccine harms, which Andrew Bridgen has campaigned a lot on and was in Parliament yesterday to talk about in his debate, the rise in deaths caused by delays in screening and diagnosis and the unfolding of NHS crisis, there are other factors clearly that are behind these statistics. More specifically, what explains excess mortality in our elderly and disabled populations during 2020, when there was virtually no excess mortality among the rest of the population? And what explains excess mortality in the same age cohort from May 2021 onwards, and thousands had already died prematurely and the worst of COVID was behind us? Surely there should be a deficit. This will be the focus of our discussion tonight. I'm here with 3 hats tonight: as a social care campaigner heading the Together Social Care team, as the co-founder of Unlock Care Homes, which, as Alan said, campaigned against the visiting restrictions in care homes and hospitals. I'm also the co-founder of the campaign Group Families Against Involuntary Medical Euthanasia, and I'll be wearing the latter two hats as I begin to unpack the hidden factors that contributed to thousands of premature deaths during lockdown and since. As the daughter of a care home resident suffering from advanced Alzheimer's, I shared the fears of other families, of physicians and dementia experts and other concerned voices when lockdown restrictions were first introduced in March 2020. We warned then of the devastating harms that the visiting bans would cause. 6 months into those restrictions, we were shouting from the rooftops about what we were witnessing. We were ignored. People were demanding, where is your evidence? Well, clearly we could not have evidence. There have been no studies carried out into what was happening. This is what was happening before our very eyes as we watched behind closed windows our loved ones deteriorate. We were ignored by the government, we were ignored by the media and by the very organisations and charities one would have hoped and expected to be shouting from the rooftops with us. Thousands of our elderly and vulnerable citizens were fast-tracked to early graves, shut away in their rooms with minimal care support, invariably with no access to medical treatment and deprived of human contact. Many gave up the will to live. Without family support, many died from neglect, dehydration, and malnutrition. And I'm going to give an example from my own mother's care home of what I was told in 2020, March. I was told that if anyone was to get sick with COVID or respiratory infections, that they would not be taken to hospital, that they would not be, the doctors were not going to be coming in, that any medical consultations would be happening over Skype, and that there would be no assistance for the dying. And I was totally shocked. I could not believe what I was hearing. Many of those people were deemed to be end of life and fast-tracked to their graves along so-called palliative care pathways. Most were not at end of life. All they needed was care, medical treatment, and the love and support of their families. Most died alone, and yet at the same time that their families were being treated like vectors of disease, unable to attend them in their last weeks and days. And this is another thing that happened during lockdown. We were told that, nice guidance is that the end of life means the last year of life. Care homes were treating end of life as the last 48 hours. So if your loved one was not in the last, what they deemed to be the last 48 hours of life, you would not be able to visit them. So as I was saying, while our families were being treated as like vectors of disease, COVID positive patients were being discharged from hospitals to live among our loved ones. I was one of the hundreds of families who wrote to MPs pleading for an urgent review of this disastrous decision. Once again, we were ignored. I wrote to my own MP. I got a cut and pasted reply. I wrote to my mother's MP, Justin Madders, who had actually been very supportive around the visiting bans, but was totally in favour of the discharge policy from hospitals into care homes. Often what was happening is that the relatives would be calling up to find out how their loved one was in the hospital, or if they were able to go and visit, and they would find that their loved one wasn't there. And they had been discharged to a care home without them even being told, often when they had lasting power of attorney, which, as we found out during lockdown, wasn't worth very much.
Can you wind? We've had 7 minutes, yeah.
Okay, right, okay. As one witness giving evidence to the Scottish COVID inquiry said, there was no ring of protection. What I was seeing was a ring of fire burning through the care home. COVID raged through the care homes in 2020. And our loved ones are sitting ducks to a virus that affected them more than anyone else. No wonder the UK COVID inquiry module on the care sector has been scheduled last, as it would be the most damning of all. I'd now like to focus on the NHS end-of-life and palliative care protocols and practices that Families Against Involuntary Medical Euthanasia and other campaign groups believe are directly responsible for many of the excess deaths we have seen over the past 4 years and are still currently witnessing. Some of you will already be aware of the shocking report commissioned by the Lords and Commons Family and Child Protection Group When End-of-Life Care Goes Wrong, which was published last year. This report exposed the abuse of end-of-life care protocols going on in hospitals, hospices and care homes in the UK today, but also in domiciliary settings. 2 of our members contributed evidence to that report. There were 16 cases that were used to evidence what was going on, but these were selected from over 600, and the authors believe these represent the tip of a very large iceberg. Campaign groups like ourselves have compelling evidence to corroborate our belief that the notorious Liverpool Care Pathway, which was supposedly outlawed in 2014 following inquiry into its abuses, is still driving NHS practice. Our concerns are shared by medics and nursing staff from within the NHS, some of whom are willing to share that evidence publicly, and some of them are here tonight. More concerning still, we have good reason to believe that the NICE end-of-life protocols that were introduced in March 2020 and May 2021, NG 163 and NG 191 respectively, established dangerous precedents in end-of-life care and are responsible for many of the excess deaths recorded during the period and since. One palliative care consultant who spoke to us in confidence referred to NG 163 as frankly dangerous, and also believes that prior to its recent revision, November 30th last year, that NG 191, the protocol that replaced it, most probably caused many, many unnecessary deaths. Revelations shared by whistleblowing nurse Linda Roberts add further weight to such our claims, as do the experience of whistleblowing care workers who shared their concerns with the campaign group Compassion in Care, and Eileen Chubb, who founded the campaign, is in the audience tonight, and she will talk about this. In addition to our own experiences, there is now mounting evidence that many of the deaths registered as COVID-19 deaths, most particularly those that took place in care homes and hospitals during lockdown, were most likely not to have been caused by exposure to the virus, but as a direct result of these protocols. These followed a familiar pattern. Treatment was withdrawn, food and fluids were denied, and then the patient would be given a lethal cocktail of benzodiazepines and opiates to assist the dying process, the very same practices adopted under the Liverpool Care Pathway. What is more deeply disturbing is that NHS protocols were evidently being used to fast-track the death of patients and care home residents who were not anywhere near in their final days of life, and could, had they been given necessary treatment and care, very possibly have recovered.
Amanda, can I hold you there, please? Because Andrew's got to go to a parliamentary
Okay, fine.
and we can come back on these things. I'm going to change the order a little bit. Thank you so much for that. Harrowing, some of it. We're going to get into it. Andrew, could we have your contribution now, please? Sorry to swap the order around, but Andrew Bridgen has to get to a debate. So I'll ask him to come in now, please.
Unless that's Andrew there on the phone, I'm not sure we've got him at the minute, Alan. We may want to go to someone else.
Okay, let's go to Patrick. If you could come in now, please, and that would be great.
Sure. Well, thank you very much, Amanda, for inviting me, and Alan for chairing. I'm just going to give you a little bit of the relevant background. You mentioned a little bit of how I got to get involved with these end-of-life pathways. But basically, I'm a retired professor and consultant neurologist from the NHS. And I got to know about the Liverpool Care Pathway when I found one of my patients was put on it over the weekend. He was doing very badly on Monday morning. I took him off it against a lot of protesting from ward staff, and he recovered quite quickly in a week or two. And he survived for 14 months further until unfortunately, again, he was taken to a different hospital, put on the LCP and died very quickly. So that's how I got involved, and I realized this was going on almost certainly throughout the NHS. And I started to try and do a little bit of what I could to publicize it. The Mail was very much involved in picking out cases from around the country, and the publicity was very good at that time. So it ended up with the Minister Norman Lamb calling a roundtable inquiry, to which I was invited. There were about 8 people there. And then this started off the Neuberger report, which, as you know, stopped the LCP. It was discontinued in 2013. And around that time, I continually tried to, where the press would listen, to talk about this, and it was obviously an ongoing problem. After 2013, we had a sudden gap. Seems like the LCP did actually stop for a year or so, but then back on hospital wards, you saw these teams reappearing, reforming, and we knew that the end-of-life care pathways were back again. And they morphed into, basically they morphed into, instead of LCP, which was definable and they were auditing every year, it morphed into a end-of-life care pathway, which was called differently in every different hospital, and they weren't auditing anything that was going on. But it was clear from what was happening around, from what you could see on the wards, that this was still going. So, I haven't done, can't say I've done a lot, but I've tried to do what I can. When people have actually contacted me, and I've attended multiple best interest meetings when asked to try and push in favor of the patient. And since dehydration is very central in these cases, with a couple of other physicians, we started off a website entitled dehydrationlifeline.org to allow people to diagnose dehydration and to know what to do if they were in that situation and their relative was being dehydrated. So that's really a summary of how I've been involved. You want some insights at all, or just you leave that to later?
Well, I think it would be useful to have a couple of insights, and then I'll come to Kevin. It may look like, just to say in advance, Andrew may, because he's got a 6:55, it's looking like he may not join us for this, and it's going to finish at 7:55. But if we're at the tail end, he can come in there, we'll see. But yes, please do share some insights, and then we'll go to Kevin.
These are main points, and they're medical insights rather than political insights.
Right.
But we've now found that end-of-life care is effectively a form of euthanasia, which is practiced throughout the NHS and care homes, and is ongoing, and if anything, spreading further. But it's difficult to get statistics on what is happening. The key thing here, and it was Amanda drew attention to this. The key entry point into these pathways is a diagnosis of dying, in quotes. And it is frequently wrong. There is no scientific way to make this diagnosis with any degree of accuracy, and therefore it is actually a guess or a prediction. So anybody who's put on diagnosis dying is in fact not dying, and if treated aggressively, would live. It is also scientifically erroneous to base any medical treatment on a prediction or a guess. That's not a diagnosis. All medical treatment is based on strict diagnostic criteria. A guess that somebody's dying should never be a door to open to lethal medication, if they have to be used at all. So that's non-evidence-based medicine. So that, that's one of the very bad things about these pathways. And so this erroneous diagnosis leads to the killing of patients that should be actively treated. Third point is end-of-life care is rapidly lethal because it combines sedation and dehydration. Those two are very, they sort of, they help, they push each other. So sedation causes somebody not to drink, and dehydration causes them to become confused and lethargic. So it's a vicious circle. Neither of those two should be allowed in medically sick patients, particularly the elderly. Elderly should never be sedated. And, people learn that at medical school because it can be lethal. And obviously nobody should be dehydrated. And then finally, one point is about midazolam. And this has become, to me, it's become clearer, particularly after COVID. And I think most of us know that the peak of COVID deaths in out of hospital patients was concurrent with the peak of midazolam use. Midazolam is a benzodiazepine. It's the most powerful one, but it has a very short half-life, so it has to be given by continuous infusion. As a result, it's particularly used for conscious sedation, what is called conscious sedation, removing teeth, that sort of thing, where you need a very short period of sedation, which turns back, which once you move it, returns to normal. It is, if you look at the license or the label for its use, end-of-life pathways is not a licensed or label use. It's an off-label use. So and the reason is because there's no medical evidence supporting, there can be no medical evidence supporting what is effectively a lethal side effect of this drug. And if you look at the British National Formulary on midazolam, you'll find that all benzodiazepines have to be given very carefully in the elderly. And secondly, there is a contraindication in the BNF to giving an opiate with midazolam, and those are actually both prescribed together. So you're effectively prescribing a lethal combination, which should be illegal. And secondly, you're giving it to a vulnerable group of patients, the elderly, the sick elderly. So again, not surprising that people die quickly from this.
Okay, thank you very much, Patrick. Now, Kevin, if we could have you, please, Professor Kevin Yuill.
Sure. Thanks for having me. I'm here to talk really more about the context in which these kind of things are happening, and to draw your attention really to proposed legislation that should probably come in this year, which is to amend the Suicide Act of 1961 to allow assisted suicide and euthanasia. So I think this will target people who feel a burden. This is the evidence that we have from other countries where it is legal. It will target people who feel a burden. Feeling a burden is a more important reason than pain in every survey that asks why, in areas where it is legal, it takes place. So where it's been in place some time, proposals have inevitably emerged to allow euthanasia for all those over the age of 75 who are, quote, tired of life. And that is the Netherlands. It originally in 2011, I believe it had 115,000 signatures behind it, that proposal. It has come up in the Netherlands twice since then. It has not been successful, but I think it's a danger. Also in Canada, which legalized euthanasia and assisted suicide in 2016, already there was a Quebec doctor who became notorious for suggesting that in fact euthanasia would be very useful to extend to minors, to children of all ages. But he also, in the same discussion, said that people who are elderly should have access to euthanasia. So I think that's part of the whole thing. I'm a historian. Part of the campaign for euthanasia, historically, it first emerged in 1870, no sooner, no later. That's, we can be fairly exact, unlike most historical points. it's exactly when it came up. And part of the campaign has always been compassion. There's no question that compassion comes into it, but it has always been coupled with social utility. And this is the problem. Serious proposals for euthanasia were part of the eugenics movement. They aimed to streamline society by getting rid of those whose lives were inconvenient to themselves, but also to others, to society more broadly. So those motivations continue today. I don't have to tell you about, I hate talking about the 1930s because I don't like to tag my opponents with the idea that they're a bunch of Nazis. And of course, they're not. They're well-meaning people. But of course, people are very familiar, I think, with the mass euthanasia that happened under the Third Reich, that began with the disabled, then with the mentally disabled, and then Jews. So it's sort of extended in that way. I'm happy to answer questions or give lectures about that because that's what I used to do. However, I'm talking really about assisted suicide and/or euthanasia, and I think assisted suicide is what is proposed in the UK, in most regions of the UK, although in Jersey it includes euthanasia, so they're different. That's not really in the UK, I know, but it seems like it to me. But in any case, assisted suicide means that the patient ingests deadly poison with the intent of killing themselves. Euthanasia is when a doctor gives a lethal injection. And I just want to make a few short points about this. I think, first of all, I hope that as many of you as possible can join me in the campaign against this legislation, because I think it's very, very dangerous. First of all, let's reject dishonest language. Killing is being sold to us by the use of the cuddly term assisted dying, or at least the relatively cuddly term. Take control of your death, which is, of course, suicide. My body, my choice. All these we're being sold something. We're being soft-soaped what is in fact actually killing. And that's what it amounts to, either oneself or the doctor killing the patient. This is not about choice, really, except for the doctor. We all have that choice already, that we can actually eventuate our own deaths. Everybody here has the power to eventuate their own deaths through, for instance, voluntary stopping eating and drinking is an effective way of actually eventuating your own death. It's not something that I would recommend, but at least you can say that everybody has the power to do that. Living, it takes actually an effort. So that's my second point, is really that the doctor is the one with the final choice. And euthanasia, where both are legal, euthanasia is by far the way it happens. So in Canada, there were fewer than 7 deaths by assisted suicide. That's amongst over 10,000 that were actually euthanasia. So the third point is the proposed legislation creates a different moral value on one group. And I think this is really its danger. It creates a different moral value for one group, the dying, and others. And in all countries where it has been legal for at least 8 years, the criteria have expanded. So in Canada, the Netherlands, Belgium, and Colombia, those who are not now dying are now included. And I agree quite with Patrick that the whole idea that you can define a group of people as dying is not a great situation. First of all, dying is part of living. You know, you live right up until that moment you die, and then you are dead. The whole dying aspect is very, very questionable in the first place, and I think it's kind of dangerous, particularly in the situation that Amanda and Patrick have talked about it, but also in this context. So in Canada, it was legalized in 2016 with the criteria of death as reasonably foreseeable, which is a fairly ridiculous phrase, but it was removed in 2020, which allowed those who were disabled, permanently disabled, the choice of lethal injection. And in March, it will allow those suffering solely from mental illness to to access euthanasia. In the Netherlands, at least 8 people suffering from nothing other than autism have been euthanized because they could not deal with the radical changes in their lives that were happening. So I think it's extended far beyond, quote, the dying. And so that's really my third point. The only thing I'd say is that the final point I'd make is that it's about social utility in the end. And although that's hidden under the whole rhetoric of choice and autonomy and all of these lovely words that we love, underneath that is social utility. It is for people whose lives are inconvenient to themselves or to other people, to society more broadly. So there's a Canadian report of the budget officer estimated that there would be $86.9 million saved if 6,461 euthanasia deaths took place in 2021. That was a complete understatement. There were over 10,000 deaths that year, and I think that they erred on the side of how much money wouldn't be saved, rather than, they were trying to make a point that it's a relatively small amount. But they did make the point that the amount saved by expanding the criteria to those suffering only from mental health would save 4 times as much per patient, some $56,000 per patient. There is money in this game, and this is a real problem that I think we should do something about. If we wish to create a culture whereby the elderly are seen as actual people, and I think we probably all agree that that is the way they should be treated in hospital, that's the way they should be treated by their families, and that's the way society in general should treat the elderly, is as valuable people. And they should be valued as persons rather than in what's called quality adjusted life years, which is a very, very blunt instrument to measure the value of somebody's life. It works in certain contexts in terms of drugs, in terms of value in drugs, but I think it's a very, very blunt instrument. We have to beware of that. And so my final plea is, please help us in resisting legalizing assisted suicide this year, when Keir Starmer, who is very, very much in favor of it, will probably come to power.
Okay, thank you very much, Kevin, and thank you to all of you. A couple of things that has really struck me. I mean, the backdrop to all of this, and it's not just in the arena of care, of course, but, the discussion of a term that Amanda used, like bed blockers, and we saw some of that during COVID, not just in terms of care, but elsewhere in the NHS. And we've heard things like coffin dodgers. There's been some notorious writers and journalists who talked about the alleged environmental crisis and, that context about older people. And there's a broader discussion about all of this, but the very specific discussion and some of the issues that have been raised are really compelling, and we should drill down on them. And Patrick, you said something that for people who are not as familiar with this discussion, would be quite shocking, which is that this combination that's provided is, or, given often without consent, is a lethal combination, and it should be illegal. Now, I got to ask you firstly, and then others can come back on this. Why do you think that is, that this is happening? If you think it should be illegal, and you've got a lot of experience in the medical arena, why has this happened, and why is it not? Have we got what Kevin alluded to, some of the terrible things that have been going on in the 1930s? Is it a kind of technocratic, just number crunching thing? Is it something more sinister? Well, what's going on, and why is it happening by people who are supposedly about caring for people?
Well, it's a complex combination of questions, but going back to what Kevin said, finances are very central here. In hospital, if you look at the number of beds in the NHS, the number has decreased progressively, and they're almost half the number of beds they were about 15, 20 years ago. And how is that possible when the older ages are increasing? And one of the reasons is this end-of-life so-called care. So there was a strong motivation to help with an increasing number of elderly. Secondly, poor numbers of nurses, difficulty with nursing. It's very hard work looking after the elderly. And that was another thing that pushed in that direction. In terms of the actual use of what should be illegal medications, I don't know how that crept in. I think it crept in slowly. It first started in hospices. Hospices are allowed different standards. They're allowed different things because everybody there is so-called dying. So, all right, we can use a medication that maybe, maybe pushed the wrong way, but we know they're going that way anyway. So let's use just a little bit of this. So that's where the cocktail all started. But effectively, this midazolam is only used in very specific situations. It's used for conscious sedation for very short periods of time. And it's used for status epilepticus, particularly to terminate ongoing seizures, particularly in children. That's it. It's not used as a benzodiazepine like Valium or anything else. The reason is because it has a very short half-life. You give it, and then in a few minutes later, it wears off. So what they have to do in the end of life care is to give it by infusion. There's one of these little machines they put by your bed and a syringe driver. And I think it all started in the environment of a hospice where people were allowed to do things. Is, well, you can't think about normal medical practice. We don't need evidence-based medicine here because these people are dying. So when that got pushed into general hospitals, that was a big leap in the wrong direction. Non-evidence-based medicine was coming into a scientific arena and taking over.
Can I just push you on that a bit? And I'm going to come to the other panelists, but just to be clear, are you saying that within the hospice, let's call it a movement, or the hospice institutions, you would also disagree with the use of it in that context? Or are you saying the big problem was that it was then put back into hospitals? Do you disagree with it in totality? What's your actual view?
Yes, I mean, you cannot just take, like Kevin was saying, you can't treat one group differently. Life is life, whether it's in a hospice or it's outside. And if you look back at Dame Cicely Saunders, who started the hospice movement, she would never have given anything that would, she stated this, she said, you must never give everything that will encourage death, that would speed up death. But that got forgotten, and that's gone out the door. Okay,
so I want to come to you, Kevin. The thing is that I know I'm sure everyone's got experiences of this, but I know my dad had MND. They call it ALS in America. We know the story of Jack Kevorkian, who some people called him Dr. Death, other people saw him as a bit of a hero. 130 people with what they called physician-assisted suicide, what you're saying is killing. And he did go to prison for 7 years in a nation that actually has the death penalty in certain states. It's an interesting question, a moral question, and all of that. But when people, that your point about death and people making decisions and just choosing to stop eating, you can do that, but if you've got certain abilities, you may be that there's all sorts of contexts, right, where you can or can't do that. There are fluids, there are other situations. I suppose the question is, to what extent from what you've heard in this, I get your general points you're making about suicide, legislation with a say, whether it's called assisted dying or euthanasia. To what extent, to what you've seen and what's been put forward both by Amanda and Patrick in this conversation, are you concerned about what's been going on with the question of the pathway, the livable pathway, care pathway, and how much it's been abused or continued now, and this discussion around hospices and in particularly in care homes? How do you see that in this context?
Well, I think, first of all, I think most doctors are good. And I think that most doctors actually really want to help people. That's why they're there. That's why they do what they do. I think the real problem comes in a sort of context where people are seen not as human beings, but as numbers, as if you're a bureaucrat. So a manager in a hospital is making decisions about people he's never met. To him, they're just such and such, age 87, rather than, an actual person who has a name, who has a huge history, who has a big extended family, and anything else like that. And I think that's the real problem, is this sort of bureaucratization that's come in and just makes decisions about human lives based on ridiculous bureaucratic notions that cannot measure lives. If one of the issues that comes up, people say, "Oh, well, if a life, somebody towards the end of life, their life isn't worth living." And I think, well, no, people who are, I don't know, in their 80s or 90s even, can be much more valuable human beings than people, for instance, who are in prison for doing a horrific crime. Who was more valuable? That is a value judgment. It's not something you can make on paper. You can't just say this person is not as valuable as this. And I think the principle of moral equality is very, very important here. And I think one of the problems that Patrick and Amanda's are talking about is this sort of bureaucratization of human beings, and this tendency to look at human beings as numbers rather than as actual people.
Yeah, thank you.
Does that answer your question?
It does. Well, to a certain extent, let's push it a little bit further, and then we're going to come to some others for questions. But Amanda, some quite gut-wrenching points that you've been making in your introduction. Most, for instance, are not at the end of life, and obviously we know many died alone and being presented as vectors of disease. We heard all about the ring of steel and the ring. You presented the ring of fire. I suppose my question is this, which some people will put forward. Look, it's to follow on from Kevin's point. Many doctors, separate to managers and bureaucrats who are looking, but many doctors go in this, many of them, not all of them, but to help people to do, some kind of service and take professional, contribute themselves enormously. And they're ameliorating and offsetting pain and a range of issues like this. To what extent, and this is following on from this, is these lethal combinations, and they should be illegal. How do you see all of this? How much do you think it's a concerted effort? How much of it is something that's just become too widely abused? What's going on here from your point of view? Someone who's both had an experience personally, but is looking at it a bit more objectively from a campaigning point of view as well. How do you see that?
Well, I think Patrick is very right. I think what happened, what practices that were accepted in the hospices have become practiced within the NHS, and we also, people in care homes are being subjected to these pathways. And I think Kevin is also very right when he talks about social utility. I think that is very much what's happening, and I think that Kevin said that it's got to do with money, and I totally agree. I think NHS managers are looking at the budgets. They're looking at people as numbers, as Kevin said. They're not looking at them as human beings. And also, there's rampant ageism within our society, but particularly, I would say, in the NHS. And I think it's a really big problem. I mean, what I wanted to, talk about was that these practices are ongoing. We've got people as we speak who are being put on pathways months, possibly years before their time. And why is that happening? Because it costs to keep them alive, and people are living longer, and they are needing to draw more on care resources. So it's much cheaper to finish them off early. And I don't see it as a plan. I don't think the government sat round a table and said, right, we're going to cull the elderly, and this is how we're going to do it. But certainly that is what is happening. This is happening. And you've got, for example, people say to us, where's the evidence? And there are many families now who have got the medical evidence. They have got the medical evidence that shows that their loved one died because of the drugs, but also possibly from the dehydration and the malnutrition. Now, we have one lady at the moment who is dying in hospital. She was very active, very fit. She was an elderly lady, 89, but she was out gardening. She had a stroke, ended up in hospital. They're refusing to put in a food tube to sustain her, in the hope that, you know, that the family hopes she might get better. Maybe she won't, but she should be given that chance. And they are saying it's inappropriate. Now, this medic told the family it's inappropriate to treat your mother. She's had, you know, virtually she's had a good innings. Another said if she was 60, we'd be treating her differently. This is outrageous, you know. And as I said, families have got their medical records. They can prove that this is happening. And we know that the clinical frailty score was being used with DNRs to put people on these pathways. So the DNR is supposed to be do not resuscitate. However, certainly during lockdown, it became shortcut for do not treat at all, withdraw fluids, withdraw treatment, withdraw food, and then when the person was so weak and they couldn't fight, put them on the drugs. And I took my mum off the pathway, but it was a fight. My mother was first put on the pathway in 2019. I refused and got her off it, got her back to health. In 2021, it happened again. She ended up in hospital during lockdown. I was shut up 7 days, told she wasn't eating and drinking enough to sustain life. Turns out they weren't assisting her to eat or drink. And when I said, no, this is not going to happen, and I have lasting power of attorney, they told me my lasting power of attorney was irrelevant, and I had to fight in the court of protection to get my mum home. Now, most families will not go down that route because they believe what the doctor is telling them. So when the doctor says it's not appropriate because, you know, it's too risky to treat. I mean, we had one lady approach us, I think she might be on the call tonight, whose father was in the care home during lockdown, and they discovered after 6 weeks of him screaming out in pain that he had a broken arm. He was taken to hospital, they refused to treat him, and he died there on the pathway. And the clinical frailty score was also being used. So if anybody had a clinical frailty score above 5, and that's anybody with dementia, because anybody with dementia has got 6 or 7, depending on the severity of the dementia. And so these were being used as a means to put people on the pathway. And you know, they continue to insist that this is just about resuscitation, but it's not. And what they are doing is they're trying to get the patient to sign a DNR when the family is not present. And if the person lacks capacity, and they're trying to get the family to sign it, but what they are doing is they're not giving a very balanced view of what the risks and benefits are. They're not explaining that these drugs that will make your loved one comfortable are actually going to kill your loved one. You know, this is not being explained to people, and people need to be given the exact, you know, information in order to make the decision. And the decision is the decision of the individual or the family if they lack capacity. And we have this lady I was just talking to you about who's been refused had been refused a food tube very quickly. The medic said to the family, these are not your decisions to make. They are our decisions to make. And yet in the NHS constitution, it says that families should be involved in all decisions around, you know, end of life care. Yeah.
Okay, we're going to come back to some of these things and what we can do about it. Kevin, I can see you want to come back. Can I get a couple of questions? And if we can hold it, and yeah, is that okay? They don't have to be questions, they can be points, but just, I know a lot of people are going to want to speak. So let's be mindful of the timeline and just indicate so I can see. I think we're going to go to Linda, but I'm having to look through okay, so we've got Rebecca first, and then if you put your hands up or I sit, and I'll try and do this as best I can. I'm on a different computer than normal, so I'll start with Rebecca.
Julie James has got her hand up. Julie James.
Julie, okay. Hello, Julie. I can't even. Oh, there we go. Right, we'll go. Rebecca, then Julie, and then we'll see some more. Thank you.
Okay, yeah, very briefly, I'll tell you what I discovered. So my mum died unexpectedly, suddenly, and after a very long fight and a very long story, I eventually got a second autopsy and toxicology tests because I suspected something had happened, and I'm an experienced nurse by background, with a care of the elderly background. And she'd gone into hospital with dehydration, which was from neglect at home with home care and in a situation of domestic abuse, and that's complicated, but she was on a court of protection welfare order and delayed getting into hospital because of lockdown, because I couldn't get to her. This was in between May and July 2020. And so a delayed admission into hospital with dehydration, actively treated for dehydration, recovering normally well with IV fluids. And then something catastrophic happened and she developed sudden vomiting out of nowhere, no reason for sudden vomiting, aspiration pneumonia, and I literally watched her drown and die, and I suspected that something had happened out of the blue. And after a long fight with the coroner, I eventually obtained a second post-mortem because I didn't think the first one was anywhere near a good description, accurate cause of death. And toxicology revealed midazolam and fentanyl in her blood. And there was no documentation for any reason for anyone to have either prescribed those drugs or given them. So she was given illegally 2 controlled drugs by someone in the hospital, and that it wasn't in the controlled drug record book. We dragged them into an inquest. Coroner just didn't know what to do, completely out of her depth, couldn't bring herself to criticise the NHS, couldn't bring herself to see that aspiration pneumonia was caused by the hospital and probably triggered by the 2 drugs. I had stacks of expert witnesses on my side, and the entire system shut down. Surrey police refused to investigate. The coroner didn't make them investigate. They all tickled around the edges. No one was prepared to recognise that this was, a shipman scenario, basically. And I caught them because I insisted on toxicology. If I hadn't done that, that evidence would have gone to cremation. And It just makes you wonder how many other cases are there out there where they weren't even talking about end of life protocols. She didn't have COVID. Somebody gave those 2 drugs. For what reason? They couldn't be bothered. They needed the bed.
Yeah. Well, okay. Thank you, Rebecca. The other thing that strikes me on this when we think about what might be done is we also have a cabinet minister for law and order, and your point about police and investigations, when the police are often now jumping to investigate what people are posting on social media but not going to burglaries, this might be another thing that we might need to get addressed in that context. Thank you. So next is Julie James, and then I've got Celia, Sam, then Eileen, in that order. So Julie, please.
Hi, Alan. Can you hear me? Yeah. Hiya. I'm actually sitting in my local hospital at the moment doing this in the relatives room. I've had to stay behind tonight because my mum's a patient here. She went in 9 weeks ago. She had a fall, broken her hip, and that was soon rectified the day after. She had a hip operation, and she was walking the day after. That was fine. But what happened in between? Neglect. She's got a grade 4 pressure sore. There's been issues with her sodium levels going down. This is why I'm here today. This is why I'm still here now. I've come in this morning and she's just not the person that she was. She's just looking, she's very confused. She's just looking blank, not really communicating much. So I asked to see a doctor. This was first thing this morning. The first thing I noticed was she was very thirsty. She was asking for water. So within half an hour, I give her 3 beakers of water, which was 600 ml of water. You could clearly see she was dehydrated. All her lips, face, everything. So I demanded to see a doctor. Apparently, she had drunk, but prior to me getting there, so she had drunk quite a lot, but she was very, very thirsty. So all week, I've been sort of battling with the doctors. I've been noticing signs of dehydration with my mum. And they've been doing tests, blood tests and everything. This sodium has been going down, the hemoglobin's been going down. So they've been doing blood tests, urine tests. And they were saying, oh, we think it's this SAIDH, which they explained to me about the salt levels, and that salt can be retained in your vessels. So I've been saying all along, she's dehydrated. I've been through this before, my family, with my dad. My mum is going down the same road as my dad did, which resulted in a big court case, H versus James, where we set a precedent in the Supreme Court, 2014, for patients who lack capacity, for families to be the patient's voice in end-of-life decisions. My mum's going down similar, when I say similar road, after admittance with a fall. They found with tests and scans and MRI scan, my mum was suffering with constipation. So they were treating her for constipation. And it was, she's having, different enemas and stuff. And problems really started from then, to be quite honest. That there's a lot's gone on. But what's going on now is this sodium level, well, exactly the same happened with my dad back in 2012. He drove himself in with stomach pains, gets all the scans, all the tests, all the relevant scans and stuff, everything come back clear. And they give a diagnosis of constipation. This is going back in 2012. My father ended up critically ill exactly 3 weeks later, severely dehydrated. They wanted to put him on the Liverpool care pathway just after 3 days of admission into critical care. A do not resuscitate. This is 3 weeks after him driving himself into the hospital and getting a diagnosis of constipation. So because they weren't really communicating, the doctors, with us, what made him critically ill in 3 weeks. So because they weren't sort of coming up with answering our questions, we wouldn't back down to them until we had an explanation. This went on for months. This went on for about 8 months. We were called into best interest meetings.
Can I ask you to sum up, because we've got quite a few people, Julie, but it's very harrowing. But just if you could give us your sum up on this, please.
Well, basically, it's dehydration, and I'm seeing it now. I'm seeing it now on the ward with my mum. On the ward, that there's all elderly patients. They are all dehydrated, and this is how it starts. It's dehydration. My mum now, she just, I'll stay here all night until I see a doctor. They've been saying all week about the sodium levels, this SAIDH. Doctor come back yesterday. No, we're ruling that out now. She was put on a fluid restriction, which I think has made her worse. It's dehydration. And I said, I've been saying all week it's dehydration because I've been through it before. So she's been unnecessarily put on a fluid restriction when she shouldn't have been. And she's just not my mum. I will stay here all night until I get this sorted. And it's dehydration, which leads to a do not resuscitate. Then I'm asking what medication she's been given as well. It's opiates. And then, they lack capacity, organ failure setting in. Then they get put on the end of life. And I can see the same patterns happening with my mum as my dad. And, I'm not very happy at all about it.
Well, we can totally understand that. And it's really important that it's on the record here. And the latter part of this meeting will be, and that's why we do need to get round everyone and come back to the speakers and then talk a bit. We're going to have Stephen Jackson, who's a lawyer. People will be familiar with law or fiction, to give us a bit of an overview about changing policy in terms of law and time legally, but also there's the political campaigning and what can be done. And we know that with the vaccine mandate, we had a big impact on that whole situation. And so we can have that discussion as well. It's very important that we get to be clear and then think about what we can all do about this. So I want to come to this. We've got Celia, Sam, Linda, and then Kay, or actually Eileen was before. So please put your hands up. We've got a certain amount of time. I'm going to try and get everyone in, but let's keep the points as specific as possible, please. So next, Celia, please. Can you turn your mic on, please, Celia? You're on mute. Thank you.
So I'm an ex-nurse. I've also been a lawyer in the past, sorting out medical negligence cases. My partner this is pre-COVID, he was admitted to hospital with a chest infection and low sodium. Within 9 days, he was euthanized. He was dehydrated for the low sodium as a treatment. I was actually accused of giving him unprescribed furosemide, so they told me to go. He'd previously had, 30 days before, a clear CT of the thorax. No cancer, nothing seen anywhere. There was an illegal do not resuscitate. When I say illegal, he was described as frail and he had no relatives when all the relatives were listed in the notes. There was an illegal DOLS, which was put on without paying any attention to the MCA 2005. And on the one day that I wasn't there, he was given diamorphine and midazolam. And there were 2 death certificates. He actually did have a huge tumour, which was missed. And the Ombudsman investigated, did find serious failings, breaches of human rights to him and to myself, but stopped short of criminality. So that's my story. And this is going on. I've never seen anything like it in my life in all 30 years as a nurse. And part of it being a respiratory nurse.
Yeah.
But I just want it known for the record, I can't get justice.
Well, can I just say, as we're talking about all of this, it absolutely strikes me that what would be very, very useful is for us to do a series of videos like we did with the NHS frontline workers about the vaccine mandate, which is what really penetrated a lot of the media. We got onto Good Morning Britain, Breakfast, BBC Breakfast, and a range of other mainstream broadcast because they saw people. This is an issue that affects millions of people up and down the country, and people feel isolated. But once we demonstrate that it's so many people around the country and this first-hand experience, so it would be very useful if people were prepared to do that in terms of campaigning and something to think about. But thank you for sharing that with Celia.
Sam and Medsai spoke to me about my case, so he's familiar with it. Right. And James Bogle as well said it was a homicide.
Wow. Okay, so we've got Linda, then Sam, Eileen, then Kay. So thank you, Celia. So Linda, please.
Yeah, hi everybody. Yes, I just wanted to quickly just tell you, my mother was one of those that was put on end of life during the COVID era. So 3 years ago in January, in fact, 3 years ago yesterday. Obviously it was locked down. We weren't allowed, I hadn't seen her for weeks. The morning that they decided to put her on end of life, I'd rung and was told that she was alert and responsive. She apparently had COVID. We don't know whether she did, but that's what they told us. Alert and responsive in the morning. Later that afternoon, we got a call to say, your mother has deteriorated. We're putting her on end of life. Now, we had no knowledge whether this was true or not. There was no informed consent. There was no discussion. They'd made a decision and they just did it. Now, I was allowed in just before she died, basically, to watch her dying with the syringe driver, with the whole, although I didn't even realize what they were doing, I've got to be honest with you, but the distress that she was going through as they put her through this was horrendous. And it's just so vivid in my mind, seeing her clutching at me, clutching at her bedclothes. It was just ghastly what they did. They gave her midazolam and oxycodone in vast quantities. It took them 2 days to kill her. And it was, to me, it was just complete murder. So that's the story. I am actually taking legal action now. The reason, and I want to say this, I am taking legal action because I want the case to go to court. I'm doing it as a medical negligence. I want the case to go to court to raise awareness that this is still happening now. As Amanda was saying, it is ongoing. There are people all over the country who are being euthanized Families are not aware what's going on, and I'm doing this case purely to raise awareness, get the case in court, and if more people can do that, we will get a bit more publicity on all of this. Now, it's going to cost me money, and I will do it. I also want to just say very quickly, I want to say a big thank you to Jackie Devoy, who is on the call. Jackie is the lady who produced a film called A Good Death, which is freely available to watch. And it was through Jackie's great perseverance in trying to get recognition for what they were doing that raised my awareness even more. I watched that film, got in touch with her, and I've been with her in her group for 2 years now, whatever it is. So I just wanted a big shout out for Jackie, big shout out for Amanda. She's working her socks off, and we're all trying to help her too. So we've got a lot of work to do. We really need your support. Everybody on this call, please get the awareness out there as much as you can. Thank you very much, Alan.
Thank you, Linda. So Sam, then Eileen McKay, and Hazel, I can see you as well. We're going to need to try and keep the comments slightly shorter, but I want to make sure everyone gets a proper chance. So Sam, please.
Thank you. Check you can hear me.
Yes, indeed, we can.
Well, first of all, I'd just like to say this has been an amazing evening with such a wide variety of very articulate contributors, and I just take my hat off to everybody that shared so much experience. But if I can put a little bit of a spanner in the works, I think there are other ways of looking at some of the stories we've been hearing about, and some of the trends, the social trends, etc. And I'm saying this as somebody who is probably of a similar vintage, I think, to Patrick Pullicino. I'm a retired professor, but in my specialty was palliative medicine. I worked in hospice and then hospital-based palliative medicine for 30 years, and I was there when the specialty was being set up. So I was a bit concerned when Patrick, you referred to end-of-life care being effectively a form of euthanasia. I hope I've not been doing euthanasia for the last 30 years before I retired. I think that it might be seen as euthanasia, but then so can a lot of mispractice, poor practice that we've heard about being seen as euthanasia. But actually, I wonder how much of it was deliberate. I think there's another view of this, is that a lot of the things that are being talked about and a lot of the cases that we uncovered in the Laws and Commons report when end-of-life care goes wrong was probably just incompetence and inexperience. We've talked a lot about the drugs, and I think I can't remember who said it, maybe a couple of speakers, that the combination of morphine and midazolam is lethal. It's contraindicated. Actually, they're not contraindicated. There are a lot of cautions about using them, but they can be used together. I've had 30, 40 years of experience of using exactly those two drugs together. I don't think I actually put anybody to death because it's a question of having expertise. All drugs can be lethal. You go to Holland and Barrett, you buy things. You go to Boots and buy paracetamol. They're lethal. It's a question of having expertise and having respect for those who have expertise and use it, but actually calling out those who don't have expertise and misuse it. And that's what we try to do with our Laws and Commons report, pointing out when people were out of their depth, not referring to specialists that would know better, and actually misusing. And just one point I do totally agree with Patrick and other speakers is that the Liverpool care pathway has not died. Our report showed that right up to last year, there were still examples of the Liverpool care pathway going on. And again, I don't think it's deliberate. I don't think anyone is saying we want to do this under the covers. They just don't know what they're doing. And I think I really want to just address that, is that we need to pay respect to those who have expertise and those who are trying to say that things could be done differently, and not polarize it, not saying, well, because I did end-of-life care, I'm a euthanasist. That's not helpful at all. So what I'm saying is, let us look at the individual situations, and I'm an expert on drugs, so I'll talk to anybody for hours on drugs and how they can be used, but don't say that the use of these drugs is inevitably lethal. because they're not.
So that's a really important point. I want to get everyone on it, but just to ask you, to push you on this a bit, Sam, in the context of these, the stories, the experience of these families and others, and what we've seen in the last period, particularly during COVID, but ongoing, are you saying that I don't want to put words in your mouth, but are you saying that you think it's all due to inexperience or some, like, maybe not malpractice, but a lack of understand? I mean, or is it, what's your view?
Alan, may I?
Yeah.
You're doing it again. You're saying it's all due to. I'm trying to say nothing is all due to anything. I'm trying to take a middle path, and I think everybody here on the panel, and we're all reasonable people. We don't say everybody. We don't tar everyone with the same brush. Yes, there are wonderful experts. Yes, there are totally incompetent people I'd rather see in jail. And by the way, I'm working in inquests who are actually calling out cases where things have gone badly wrong, and whether it was deliberate or not, people should pay the price. So that's why I'm giving expert evidence to courts. But yes, the point is that we need to be very searching and very subtle, and we made lots of recommendations in the when end of life care goes wrong report about putting this right. Unfortunately, not one single MP actually stood up and supported us at the time. Andrew Bridgen has said good things about it. Others have individually said good things about it, but it just fell on deaf ears.
Right. Okay. Well, that's something we'll come back to in terms of what can be done. Now, listen, it's just gone 1:45. I know Kevin's got to go. Andrew's going to come back in, and we want to also have Stephen Jackson. So I know we've got Eileen and Kay. Can I ask you both to be brief? I'm going to push people now in terms of time because we've got a lot to get in, and I'm going to interrupt more. So don't be offended or scream at me. I apologise in advance. So Eileen and then Kay, please. And then Stephen, I'm going to come to you just with a legal view on it, and I'm going to come back to the speakers. So, yes, thanks.
Hi, yep. I'm a former whistleblower who lost my job along with many other people for actually reporting dead people's drugs being used and administered to people in lethal doses to keep them quiet. So it's not always done in a rational way. Staff can access these drugs quite easily and misuse them quite easily, and it's quite widespread. I just want to talk briefly about our COVID reports, 48 reports, just touching very briefly on 3 of the issues. And that is people were drugged with sedative drugs. Hundreds of whistleblowers came to us from across the country and said people have been drugged to keep them quiet and keep them in their rooms because they were wandering into other rooms. And because of the government policy and discharging people with COVID, they sedated people and they locked them in their rooms to stop them going into rooms of patients that had been admitted from hospital. That is horrendous. The other thing that was happening was that people were falling and suffering head injuries as a result of being given sedative drugs. So it was a complete vicious circle where there was the most horrendous suffering and there's nowhere for people to go. We've supported 13,000 whistleblowers and 9,000 family members, and there is nowhere for people to go with their concerns. We'll be publishing in the next 3 weeks our report on regulators and professional bodies, and we have evidence from 26,000 members of the public who are saying that when you raise these issues, nothing happens. One further thing, which I just want to touch on briefly, is that thousands of staff left the care sector after the COVID, and hundreds of those staff were whistleblowers who were forced out. So the care sector is still seeing widespread abuse and neglect because the best of the staff have been forced out. And that's why we campaign for Edna's Law, to protect whistleblowers and the public.
All right, thank you very much. We also know that we lost over 40,000 carers as well with the mandate that was imposed, many more than them, many with long-term experience. So thank you for that contribution. Kate.
Hi there, can you hear me okay?
Yes, we can.
Okay. So yeah, I just wanted to sort of come back to a couple of points that people have already made, actually. Like Eileen's just mentioned, you know, not being able to get justice from anyone, like the health, the ombudsman, PALS, safeguarding, CQC, the hospital complaint system. They're all, you can't get justice from any of them, you know. And in terms of taking, you know, things to court, I mean, we're 3 years, 3-4 years down the line now. And we haven't seen a single case come to court yet about this. So justice is being denied. The media aren't covering this, and they won't cover it until the court cases come through. So, but we all know that people are being killed. They've been put on these drugs. Not everybody needs these drugs. Who needs these drugs? Only people who are really in, extreme pain need, opioids. Most people who are dying don't need these sorts of drugs. Agitation. Midazolam is used for agitation. I'm agitated now. I'm a little bit annoyed. Are they going to give me drugs if I go in? And they can give midazolam for absolutely anything, and they have been. These are old drugs. Opioids are old drugs. If you give an opioid, then you're going to have issues with constipation. You're going to have issues with falls. You're going to have issues with itchiness and confusion. You're going to have to give laxatives. They're not cheap drugs. With midazolam, you're going to have like catheters. There's going to be care issues. The person's going to need more care, more turning, to make sure they don't get pressure sores. It's a horrible way to die. And I agree with Patrick. I think it should be illegal in all but very, very few cases to use midazolam. Very, very few people actually need it. So, and as far as legality is concerned, they're ignoring powers of attorney, they're ignoring informed consent, and they're fast tracking people using the clinical frailty score, which is quite frankly discriminatory, and I don't know why it hasn't been challenged. Thank you.
Right, thank you very much. Just to say, I'm going to ask Kevin to come in then. I know Patrick. I'm going to ask Kevin, Patrick, and Amanda to come in. Then I'm going to ask Stephen to speak. I'll just say this thing that the treatment of older people in society more broadly, and I've just experienced this again now with my mother, and she's actually in an independent living place, but it's managed by a situation, people who've got care homes and all sorts, that when they're in arguments or discussions about things, the expectation is they're just going to fall off the side of the cliff, and the treatment, and that's for people who can represent themselves somewhat a little bit more fully, and that kind of thing. And I think the question that you raised, Kevin, about persons and people and autonomy and choice and respect, and how we think about an intergenerational society with people and what we want and the public being heard is sort of crucial. It's come out for me in this discussion as something that's being essential. But if you would give us some last thoughts, I know you've got to get off, and obviously this is going to go, and we're going to talk about campaigning elements, but just if you could give us some reflections, Kevin, that would be really helpful, please.
I just want to make just a few last points. I think one of the things that's come out, particularly with this post office scandal, is the lack of trust that people have when they're faced with a bureaucracy against which they can do nothing. They bang their heads against the walls. And I think everybody here has probably had that experience. That's why we all related to that program so very carefully, because that is my experience in dealing with this. I should say 1 year ago today, we lost my mother-in-law, and 3 years ago today, I lost my father. And in both of these situations, I had similar experiences, and you felt frustrated. I didn't think he got the right care. I was mystified at why my mother-in-law was, various different things. I mean, death is a pretty horrible thing. So it's always going to have these emotional aspects. And one of the things that strikes me is that we don't have trust anymore. And our trust is eroded in the authorities, and the medical authorities are like every other authority that we have. And the failure to get answers to these things, it adds to people's frustration. I think there are two other elements that I would mention. I think that there is an individualization that's where people, yes, a doctor treats a patient, but there's a line between the patient and the human being, and I think a lot of doctors are not able to draw that line very effectively. And I think that's one of the problems, is that they treat, and then they forget that there's a whole infrastructure behind a person. There's not just one person. There's a person and the people that they love and the people that love them, and it goes out, etc. So I think one of the problems is individualization, viewing people as individuals rather than as part of a family, of a community, and as I said in the first place, human beings. Finally, I would draw attention to shrinking resources. I think people have this perception that there's a lack of resources. There are more resources than there ever have been. in the NHS and in various different health circumstances, but yet we have this perception that there's not enough. And I think one of the problems I see is that there's this scarcity idea that, oh, how are we going to divide this pie? And therefore, some people are sort of pushed and they decide to prioritize patients. Doctors have always prioritized patients, but it hasn't upset us that much until very, very recently. So yes, my only last point is just to please prevent the assisted suicide bill from actually coming, because I think that's essential for the culture that we're all disturbed by. Thanks.
Thank you very much, Kevin. So
I'm going to go now, by the way.
Appreciated it. Thank you. Patrick, could we come to you, please?
Yes. Well, it's been very interesting and very harrowing to hear the different stories, and very sad too. And I appreciate Sam's protestations about this pathway. But the issue about the pathway and all the pathways that are going on was central to the LCP. And it was that people are making a diagnosis of dying and then giving these medications. You cannot make a diagnosis of dying. And unfortunately, palliative care teams continue to do it every day. So-and-so is dying, so-and-so is dying. You know, that has to be taken right out of hospitals. You cannot make that diagnosis. And it's not the individuals, it's the pathway. You know, that is why they're lethal, because you're assuming the person, or you're making the diagnosis they're dying, and then you make sure that, well, not make sure it happens, but you use those lethal medications that does end up in death. So I think it's happening, and you cannot say that this is not euthanasia. I'm sorry. And I think it just has to be taken out of the health system. And those combination of drugs, I know that midazolam can be used, or diazepam can be used, or benzodiazepines can be used with opiates, but they're dangerous. And to use them in a sick elderly person, to my mind, is criminal.
Thank you very much, Patrick. Now, Amanda, I come to you, but I know that it may be useful just to bring Stephen in just before we do that, to give us a little thought and some reflection on the legals, because I think you'll want to talk a bit about potentially campaigning about what can be done. So, Stephen Jackson, if we could invite you in to give us a bit of an overview as to, you've worked with families before in relationship to the state. We know that you know, the question of changing laws has lots of challenges, but also what can be done politically. But just some reflections and thoughts on what you've heard and what can be done, class action lawsuits, other things like that. People will be familiar with some of the work you've done already.
Well, Alan, you alluded earlier to the success in the campaign with against vaccination of the health workers. We weren't successful in the first place in relation to the care home workers. That went through, and we lost 40,000 or more workers from that sector. The reason, but we were successful the second time round. Why was that? It's because the campaign was successful. We didn't manage to get a new law passed. We got them to stop the bad one which they were putting in place. And I think, so my perspective on it is that if we think about, well, let's put all our efforts into changing the law, yes, that might be a longer term objective, but it ain't going to happen very quickly. It's the campaigning, it's the awareness which is going to change things for us, as it did on that occasion, and it has potential to do that happen. It has potential to do this time. I think your videos is an excellent idea. We need to get the stories out there that people understand. That's what will make things happen. That's what's happened with the post office, the biggest story in the ITV. We just do it on a cheaper scale, frankly, and quicker. I was just going to pick a few things. I wasn't going to mention the personal anecdote, but I think it's useful as listening to people, and really great to hear Sam's contribution, as well as Patrick and Kevin. But my own experience, and what's really interesting, is that so many of us have our own personal experiences. That tells us how widespread this problem is. But my own experiences, for my father-in-law, he was given the midazolam morphine mix, by the hospice nurses who were introduced when the doctor came around and said, yes, I assess you as dying. 3 or 4 days at most, but but not getting better after this. Called in the hospice nurses, they decided through their own good nature that midazolam morphine was appropriate, and they said, okay, he's calm now. And they wanted to administer the syringe. And fortunately, because we were aware, the family were aware of what that meant, what the syringe meant, we said no. So it wasn't administered. After 8 hours rest or so, my father-in-law recovered. He had his antibiotics to remove the pneumonia, and he was still with us for another 5 or 6 months later. So, and the point about that is that I saw those nurses come in, to pick up on Sam's point. I saw those nurses come in, and they were beautiful, intelligent, thoughtful people who want to do their best. I still think of them as angels of death. That's what they would have achieved. But was it deliberate? No. Was it incompetence? I'm not sure about incompetence. If it was trained incompetence, where's this coming from the top? I mean, is there are we coming back into directions and a political decision, financial decisions to have these pathways, these drugs still used in this way? I'm not sure. There are other people. Chris Littlewood on Twitter is great about this. Well worth engaging with him. But I think that this is all a mixture. As Sam said, it's not all one thing or the other. But if we have awareness of people that as to what these things do, about dehydration, about what these drugs do, then people are in a position to take power and stop this happening for their own relatives in the first place. That's one great start. No matter what happens, how long it takes to change the law, if we can get individuals to understand, then they will be grateful to us and we'll be grateful to them also. I'm not quite sure what else I can usefully say in this last minute. We're over time already.
That's okay. So, Stephen, thank you very much for that. So I think that brings us nicely to come back to Amanda to have some reflections and thoughts. And then I'll say a couple of things just at the end. So over to you, Amanda, please. Or you need to take your mute button off, please.
Sorry. Yeah, very quickly coming back to Stephen. I think sometimes it is incompetence, but I think also that there's a cultural problem, as I alluded to before. But also, I think it's our tick box kind of culture that we have. The idea that we don't defer, to the experts, to the palliative care experts, but we are, nurses and doctors who do not have the necessary experience are following guidelines. And this is the problem, I think, is one of the problems. And that goes right through the whole health and care sector. I think this idea that we follow guidelines, we're not actually relying on the individual person to make the decisions, that people are following blanket guidelines about everything. Coming to the campaigning, I mean, what I think needs to happen and what campaigners feel needs to happen is there needs to be an urgent review of these protocols, not just the NG 191, which is still in existence but has been altered recently, has been amended to remove the drugs. Those drugs are still in NG 31. And the problem is that these protocols are being abused. And so we need to have an urgent review of these protocols and the drugs that are prescribed, I think. And with all, due respect to Sam Ahmadzai, he is a very experienced practitioner, 30 years. If he would have difficulty sometimes deciding if somebody was dying, but he has a far better idea than most of the people that are administering these drugs. And I think that is the problem. When it comes to campaigning, I think what I was saying before about being very grateful for all the people that have come on tonight is that we need you. We need the public. Without the public, we will not get change. We need the public. So we need you to come on board and help us. Now, Stephen was talking about, he knew what it meant when these drugs were suggested, and they said no. Most families don't, and I think this is something that we need to be thinking of. And Families Against Involuntary Medical Euthanasia, we're currently in the process of drawing up guidelines that we want to publish, that we will be advising families about what forms they need to fill in, what they need to do, things to look out for, I think this would be very, very useful practically for families facing this situation. And many of us are growing old, our relatives are, our society is getting older. We need people are drawing on more care, having to draw on more care. They're ending up in hospital because of the poor social care sector. So many people ending up in hospital and ended up never ever coming out of there. So I think we need the public behind us on this. And yeah, that's what I'd like to say.
Thank you very much, Amanda. So Andrew Bridgen's come back. He said, I'm very, very sorry. We're still voting. So I think he's going to post some comments and he's going to share. I think just to say that there's an enormous opportunity because of many reasons, but partly because of what people have seen with the postal office, partly because what we've known has happened before when we did actually get people on the front line, real people, not just Gobby Allen, right, but lots of people who have first-hand experience. They're everyday people that with our families, our loved ones, some of the most important, precious people in our lives and how they're treated. That really resonates with people up and down the country, and many find it completely unacceptable. I think we have to have robust discussions as well as also that, because this question of what life and what's worth it sometimes is somewhat cavalierly dealt with these days, we know, and that's part of the broader backdrop. But I think that videos and some of these things we've seen today, and we certainly at Together are going to be up for using what people have said today, but we should think about campaigning videos and also about approaching and targeting a range of, or the cabinet obviously, but shadow cabinet ministers, but up and down across the country in terms of the media, getting out to the public, in terms of care home institutions, and in terms of all of the coordinating oversight institutions, Royal College of Nursing, Royal College of surgeons, everyone basically, and going out to them in a similar fashion as what we did with the vaccine mandates. And our local, regional and national organisers should be involved with that, with local hubs. You should get involved in the same way that we're doing around the net zero pledge for transparency about the impacts that we've seen, things like roadblocks and other things happening, and people have been very active in that particular arena. This is something that's impacting millions of people. And in the end, it's about us and about us making decisions or being sidelined and being treated with contempt and disregard. And frankly, I can't think of anything more serious, really, in the similar fashion as the way some of our children have been dealt with and sometimes continue to be dealt with, both during COVID and subsequently, elderly and most vulnerable. So I would invite everyone to get involved who's watching this and to certainly join as a member. One of the things about joining as a member is that enables us to carry on campaigning, doing these things, to lobby, to organise. But other people who may have their own networks who aren't currently in this discussion with Amanda and the others that have spoken, indeed, thank you to Jackie Devoy, a very, very important contribution. But everyone that's spoken tonight and the panelists, I want to thank you very much for doing this. And Together and the cabinet and the role that Amanda's playing, the goal is to get everyone that we can to get involved in campaigning and act as a kind of umbrella, as we have done in other areas, and really change the landscape, right? It's one thing to understand it, it's another to shine a light on it, and to make sure we lobby our MPs and councillors and NHS trusts and the private sector and home care owners, and to get that hearts and minds, the information, and address it. And that also means a question about how we organise our healthcare and social care. And we've got a cabinet chair for health, and indeed, as we have for law and order and law and society, and all these issues need to be addressed, and the question of resources that we are putting in or not, efficiency in terms of things. But right now, it strikes me that we have a very good opportunity if we get enough people to get involved. And that really means in the election year to make it a big issue. So please join us. Please come back to us if you're interested. Let us know at togetherdeclaration.org. Come on the site, email us, let us know on our socials at TogetherDec and elsewhere. You know how to do it. And give us an indication of you want to help, and also our local and regional groups and networks. And if you're watching this and you're not in contact with us, please do get in touch and we can look at taking this to the next step. And we'll have a follow-up session. And I think it would be very good to do a public event where we have it in real-time physical space, and do some of these around the country as well with smaller groups and bigger events. So On that note, I want to thank everyone. I know we're time sensitive and I have in bad form run over, but thank you very much to the panelists. Thank you for all of you for your contributions to speaking tonight, and do get involved. And remember, we can change things in spite of the idea that nothing ever changes and nothing can ever be done and people becoming cynical and a lot of people being politically hopeless. We can change things when we do it together. We're always better and stronger together. So please do get involved. And let's see if we can make something change around this together.